Many surgeons use expansile gas like C3F8 in various Descemet membrane problems, but it is expensive, risky, and needs supine positioning of the patient for a long time. Instead, we can use air in these cases. This video is all about the power of air bubble. Case scenario 1. Descemet detachment at the end of phacosurgery. Otherwise an uneventful phacosurgery. DM detachment happened at the end during hydration of the left hand side port. Watch it again in slow motion. Movement of detached DM noticed. Air bubble was injected from right hand side port. Unfortunately, it went into the interface and detected immediately. That air bubble was removed. Air bubble was again re-injected from 6 o'clock position via 30 gauge needle. Now the air bubble was in right plane. Further manipulation via the main port to inflate the anterior chamber. More air was injected via the right hand side port to give full tamponade. IOP checked and kept at a higher side. Air bubble was removed partially after 1 hour and replaced with balanced salt solution. On next day, small air bubble noted, moderate corneal edema, DM well attached, visual acuity of 20/60. After 7 days, mild corneal edema, DM folds visible, vision 20/40. After 3 weeks, cornea crystal clear, but DM folds still visible in retroillumination, vision 20/20. Moral of the story: don't panic, keep your cool. Try to find out the area where DM is still attached. Air bubble is a powerful instrument. Case 2. Descemet detachment in phacosurgery but detected in early post-op period. This patient was referred 6 days after an uneventful phacosurgery. Best corrected visual acuity 2400. Gross corneal edema. DM detachment suspected during slit lamp examination. Anterior segment OCT confirmed DM detachment with some area of attachment in upper part. Under perivalvular anesthesia, a small anterior chamber entry port was made at 10 o'clock position. Air was injected into the anterior chamber till it was full. IOP kept on higher side. After 1 hour, loose epithelium was removed and cornea appeared much clearer except few DM folds. Part of the ear was replaced by balanced salt solution. Suture was placed in original main port. BCL at the end of surgery. After 4 hours, best corrected visual acuity 20/60, cornea clear, DM well attached. After 7 days, cornea absolutely clear and vision 20/20. Moral of the story: always get an anterior segment OCT before injecting ear. Full chamber ear for 1 hour is very powerful to reattach the DM. Replace part of the ear with BSS. Case 3. Rebubbling in donor dislocation following DSEK. Donor dislocation is a common complication in DSEK procedure. It happens within 24 to 48 hours. And immediate rebubbling is the answer. Here, rebubbling was done under topical anesthesia. 2 new side ports were made. Air was injected into anterior chamber. External manipulation, massaging and centering of the donor button done. More air bubble to make the eyeball tight. Immediate anterior segment OCT confirmed nice reattachment of donor button. After 4 hours, cornea appeared much clearer. Part of the ear was replaced by balance salt solution. Patient kept in supine position for next 4 to 6 hours. OCT image is helpful to find out fluid cleft before sending the patient back. Moral of the story: full chamber ear for 4 hours is very powerful to reattach donor button. Replace part of the ear with balance salt solution. Always check interface status by anterior segment OCT before discharge. Case 4. Double anterior chamber in DALK. Double anterior chamber rarely happens in deep anterior lamellar keratoplasty or DALK procedure. Here, Descemet membrane falls back due to interface fluid accumulation. In this case, the interface fluid was drained fast. To begin with, air injection was tried with 30 gauge needle. The interface was checked by asking the patient to look in different directions. Still, the air tamponade was not good in this case. So a small side port entry was made, and further air was injected through this port to achieve good tamponade. Interface was checked immediately by anterior segment OCT. Next day, air bubble reduced in size and DM was well attached. This was the status after 4 weeks. Cornea clear, vision 20/60, DM well attached and confirmed by anterior segment OCT. Moral of the story: full chamber air for overnight is very powerful to reattach Descemet. Again check interface status next day by anterior segment OCT. Case 5. Acute hydrops in keratoconus. Here is a case of acute hydrops where similar principle of air injection was used. Additional intrastromal transfixation multiple sutures were helpful. Patient was asked to maintain supine position for overnight. Day 3 after air injection, corneal edema much less with presence of small air bubble. Good corneal scar after 4 weeks with partial clear pupil and vision of 20/100. Conclusion: air bubble is an alternative powerful way of managing these conditions. It does not cost anything. Timing of keeping full chamber air varies with different cases and is very important. Thank you for your kind attention.